Hello. Can you hear me, first of all? Excellent. I've been told I must stand at the lectern, which is always really difficult for me, but I'll do my very best. First of all, thank you very much for coming along today. I'm very grateful to have the opportunity to talk with you. My name's Gordon King. I'm the Deputy Director of Mental Health, Learning Disability and Specialty Services, which is effectively the prisons and various other bits that we do for Northamptonshire Healthcare Foundation Trust. I'll say NHFT a few times, which is just the abbreviation. I'm aware that there might be other people in the room with organisations that are also called NHFT. I think there might be some colleagues from Nottinghamshire, so forgive me on that one. And my colleague Judith Glashan here, who is chair of our BME. So it's about how we've managed to embed some of the things we want to do. And I was particularly struck by some of the conversations just before this session, before the break. And I'm very interested to hear some of the points made about the extreme challenges we're all in at the moment within the NHS and social care, around different competing financial priorities and how things can easily slip. I'm aware that the title kind of comes under integrated services and key localities, but you'll forgive me if I take that in a very broad context of this is what we're doing within this trust to improve what we think are services, to hopefully improve services of BME service users and carers and their families, and also to do a number of other things as well about changing attitudes within the trust. So that's what we're going to try and do. So this isn't some polished PowerPoint presentation filled with statistics. I've got all those if people are interested, and I'm quite happy to send them all to you at the end of this if you give us your individual details. But forgive me if before lunch I don't do that to you all. So this is by nature both hopefully pragmatic. Some of the things we've learned, some of the things we've got wrong, some of the things we've got right, and also an opportunity for us to talk through that. I think it'll probably last about 20 minutes, 25 minutes at the very most, and then we can get into some conversations to make sure that we're finished in time for lunch. If there's anything burning that people can't wait till the end of the presentation, I'm happy to take some interjections, but if not, we can wait till the end. And then I think we have to do it with a microphone because there's people externally watching this particular broadcast. So, moving ahead, delivering the quality and health services of BME communities. Where did we start? What's this all about? Well, it really started with a conversation between Dr. Vivian Cisse, who's the chair of the National BME Network. Some people know Dr. Vivian, and some of the work that she was doing around something called reverse commissioning. Well, the reverse commissioning model was really interesting, some values-based commissioning thinking around how do you improve services for people from BME communities. And it was created around the Brighton area to address some specific inequalities that had been identified there. Dr. Vivian had had a conversation with my chief exec, Angela Hillary, who'd expressed, as I expected her to, because she's very passionate about this agenda, some interest in exploring how we could be one of the pilots. And effectively it turned out that we were one of the pilots. And I think we were the first, and I think the two other trusts got engaged with it as well. I want to really be clear that without that input and impetus, it might have been very difficult, because I think it was a real catalyst for us to say, we're engaged with this. And when I joined the trust a couple of years ago, my questions were, well, it's been kind of on the back burner for 6 months. We've sort of said we'll do it. What is it? How are we going to deliver something that makes a genuine difference? How is it really going to impact upon, my view, how does it impact upon improving services for people from BME communities and their families and carers? And how can we turn it into something that's not just, let's run a project, get a few brownie points, and then drop it in a year's time when everything looks as if we've kind of done what we need to do. In other words, I can't, and my chief execs have the same view, and the BME network colleagues would hold us to this, we can't be in a position where we're just doing things for a year or two and not making them sustainable. So how do we use the catalyst to turn something real into a long-standing attempt by a smallish, middle-ranking community mental health trust, and without a particular provenance of engagement in this area? How do we do something really different and quite ambitious? So that's effectively what we're going to talk about. So it started off by Dr. Vivian and her team doing some analysis of data. I'm not going to go through this data, but we have it all if people are interested. The data was from, and I'll say a few moments about why I think this might be important to colleagues if you're in a similar, and I think we're almost contractually obliged to use the term journey, but you know what I mean. If you're in a similar journey to us, then you want to probably have this conversation with yourselves about what we mean by data. The data we had that was given over a 2-day period, I think just before Christmas Day, that was a bit old. It was, I just knocked that microphone, apologies. It was a bit old. It went from 2011, in fact it was only to 2013, I think. and a number of issues were raised, and none of them will be surprising to people who are engaged in this area. So, seclusion, proportion of BME service users secluded, according to the analysis by the network, was higher than expected within our data set. Again, some stuff around the detention, the mental health, that proportion within sections. Now, we know this fits extremely well with national guidelines, with the national statistics and the national picture. So this wasn't particularly surprising to me. I'm a mental health nurse. I've been involved in the health service for 32 years. I've engaged in forensic services, drugs and alcohol, and I've worked in a number of different settings. So none of this is particularly surprising. And I've got a particular interest in this agenda. Referral to services was the one I was particularly interested in. And this is the issue about higher number of agencies like the police and courts referring people from BME backgrounds as opposed to GPs. And a few more, which were around CTOs, psychological therapies, which is IAP, the improving access to psychological therapies, and also personal health budgets. Now, here's where it gets interesting. Here's where you have to have the honest conversation inside an organisation about what does this data really mean. And you've got 2 or 3 options. You can either say, well, actually, we think the data's really old. It's not particularly good. We don't actually think that. To refresh as a result of all of that, just to close that one down, and we ended up with 4 specific task and finish groups around seclusion, control and restraint, detention under the Mental Health Act, specific issues around service data. Are we in the right place in terms of looking at our referral pathways, and what sort of picture is that telling us about how people are coming into our services? And then a specific issue on psychological therapies, IAP. Are people being referred to IAPT properly, or are they just being given antidepressants? I suppose, is the basic exam question that we were looking at. So this looks like a really boring governance slide, and in a sense it is, but the reason I put it up is because actually I said earlier about making this kind of thing sustainable. So right from the outset, I worked very, very hard to make sure that we had a proper structure in place that looked as if this was here to stay, and it was going to be robust enough to stand the buffets that we would get as we went through, the challenges that we'd get internally and externally. And I'll say a bit more about those shortly, about how we can begin to move forward. So there was a steering group which I was fortunate enough to be asked to chair, and I've got specific interest and experience around engagement with different groups in various aspects of my previous working life. Then there's an assurance group that we set up with BME Network, task and finish groups leads, and under that we set up very specific task and finish groups, because right from the outset I said really clearly this cannot be a talking shop. This has to be something that really begins to incrementally, however hard it is, however long it takes us, and we're in this for the long haul as a trust, how can we begin to really get inside some of the things that I think we need to do, and make it and genuinely come up with some outcomes and some outputs that make a difference. And I'll say something here about sustainability. One of the things we did really early on was seek champions within the trust. So, and it's not, again, not a trust with a particularly strong provenance, but very, very fortunate that some key people within the trust, chief execs, and some key, the chief exec and some of the key people were very keen to support this, even if they weren't sure necessarily where it might go, but a strong steer. So we got some champions within the non-exec group. Judith and colleagues did presentations to the board. I was able to talk about it at different levels. So it's really interesting that over an 18-month period, we went from it being nothing more than an embryonic idea about something we might want to look at, into actually one of the 5 key quality domains on our quality strategy going forward. And if you go on the website, it's there really clearly, which is important. It might just be words, you will say, but actually it's a very, very important, I think, commitment that the Trust has made, as well as the amount of time and effort that people have put into getting this off the ground. And it's clear that there's no money involved in this. You know, we've done this within the obviously existing framework of financial difficulty and all the rest of it. So, a little bit about the work stream. I'm not going to go into this in great depth and detail. We have got all of this on action plans if people are interested. Some of the things that we've been looking at and we've been working on, and this has been led by, it's really important to say that we've had community leaders. In fact, I'll go back a step, actually. One of the 3 things in my mind and in the board, in the steering group's mind, what we wanted to achieve were, over here we've got a group of service users who are not really representative of the wider population of Northamptonshire, and certainly not representative of the people who come through our services. Trusts and other organisations tend to use the same faces because it's comfortable. Now, I'm not going to get into what that means in terms of how we've selected or self-selected those individuals, but frankly, I wasn't particularly happy that we weren't necessarily representing the diversity of our experiences and our lived experience of our users. So that was one bit. Over here, we weren't engaged in any shape or form with community groups from BME communities, faith groups, church groups, other groups that wanted to have conversations with us about, actually, we're not really sure how to access the services, we've got some issues of stigma in our community we'd like to work with you on. All of that kind of thing was really a fairly low level. So we embarked on a great community engagement piece, and we had a number of events that about kickstarting this off, and also about growing the service user component. So service users and community group leaders and people with lived experience from within the trust have been absolutely co-producing this all the way through. I should have said that to the outset, but it's fairly important. So moving on to the impact of the work streams, very briefly, some of the things we've been doing, and again I can talk about this in more detail later, is about development of this cultural competency toolkit that's been absolutely worked on by service users and community groups themselves, and that was specifically around gaps in knowledge of health professionals. We've done a big training exercise that we've developed ourselves across the trust. Very, very different from traditional equality and diversity type training. Really embedded and quite challenging, actually, about expectations, personal thoughts, views of mental health and race, views of mental health, ethnicity, views of what we mean by cultural engagement and community engagement. And it's been very, very challenging for staff, and actually has been extraordinarily powerful, I think. And we've developed that partly on the back of the reverse commissioning training, and we've kind of developed and shaped that ourselves. Something here that people have been talking about in terms of body cameras, which is something we're going to pilot, which is really around wearing body cameras in times of restraint, which is partly contentious, but actually has been shown to be very efficacious in other areas, and something we're keen to pilot. And that's been a very strong view of our service users and carers, that actually this is something we really want to look at in terms of how we begin to change behaviours and challenge attitudes, and make sure that we're measuring the right things as we go through seclusion and restraint, which is a very big concern to many of our communities. You know, what's going to happen to me when I'm admitted? Am I going to be secluded and restrained all the time? And if so, is it because of what I look like and how, and how big I am, effectively? And that's something I've been extremely interested in my previous work. Change behaviour, that's partly to do with the sorts of challenging we've done around the training, and making sure that service users are at the very heart of challenging staff about attitudes and ingrained attitudes. And if I use terms like structural and institutional, attitudinal stuff, then you know what I mean. It's the sorts of stuff that I think has grown up in mental health over many, many years. I'm not saying we're any worse or any better than anywhere else, but it certainly exists, and it's worth challenging. On the basis that if you can get services right for people who are really, really worried about coming into services, then you get them right for everybody. So there's a real win-win here, I think. Detention under the Mental Health Act, that was around beginning to look with the junior doctors at the audit of section papers. Let's explore the narrative around why people from BME backgrounds get sectioned more often. Let's think about the decision-making practices and work with the AMPs. Are there any attitudinal things we need to think about there? So we've been doing that work as well. It mentions the BME community engagement. I mean, that's been really, really interesting to listen to what different communities, a variety of communities, are telling us about the sorts of things that they experience when they try and access our services. And that's been, I think, probably one of the most powerful things I think we've been involved with, actually. And people saying, we don't have that information. And when we go to our GPs, that's not what they tell us. So some of that stuff has been really interesting. And then something around police involvement. We've been very fortunate that we've been trialling the police triage car. So we have nurses that will be going out in a police car with the police, doing 136 work on the streets. And obviously, the crucial thing about that is, are we then making sure that the police are fully, and they have their own training, but are they working with us around attitudes to mental health? That's really about some very specific and detailed work we've been doing around self-referral and improving the issues of self-referral from people within BME communities, making sure they know about it, how to do it, making sure GPs are clued up about that, making sure that our IAPT workers, because we run the IAPT service, are fully cognizant of the work we're trying to do. Again, it sounds a little bit like just raising awareness, and forgive me if that's what some of it is, but actually you begin to challenge these preconceptions and things begin to change and happen. And then we've done a lot of stuff around kind of mapping community groups. We're still in the process of trying to work through some attitudinal stuff about access to psychological services and how we can do some work on that. And there's a whole range of publicity material associated with it. So, what are we trying to achieve? I've said some of the things I think we're trying to achieve. I think it's quite ambitious, actually. And I'm not saying we've got it all in the right place. But what we're really trying to achieve is a focus on deliverables. This can't just be, well, we've had a look at some section papers, we've had a chat about some publicity in GP surgeries. It has to be about how are the services we're delivering actually improving for people from BME service, for BME communities, carers, families. How are we beginning to make a real change around that? We think we're starting to get there, but if we don't focus on outcomes and outputs, then it will just be so much hot air. We've been really ambitious and made sure that the RES is right at the very heart of our action plan. And I make no apologies for that, because actually we take the view that focusing on the outcomes and outputs from the RES and focusing on the ambitions and aims of the RES is crucial to making sure that we as a trust not only begin to make sure that we're meeting our responsibilities to the wider community, but also that we're meeting responsibilities to the staff that we have. And I don't need to go in all the details of the RES with colleagues in this room. I'm sure you're very familiar with it. But we've made that part and parcel of the work we do. The training awareness piece is fairly substantial, as I said earlier. We've done very specific training developed to meet the needs of local communities, and we're very engaged in delivering that across the trust. We've had Police Mind, Health Watch colleagues, local county council colleagues, as well as people with lived experience and community leaders on those training groups. It's been very, very interesting. Working with BME service users in a real true partnership, I think, has been such an important part of the work we've done. And are we there yet? Absolutely not. Are we there with our co-production and our recovery model and our work around co-production generally within the trust? No, we're not. I think we were an awful long way further ahead than we were a couple of years ago. I think we worked really hard with colleagues from INROC to do some of that. And my challenge to the services is, while you're galloping ahead in developing recovery colleges and while you're doing all the work around co-production, are we retaining and absolutely emphasising the focus on making sure that the people we're working with through the Moving Ahead project and through reverse commissioning are at the very forefront of that, so that we don't end up going in a great big circle and in 3 years' time having a recovery college that effectively just does the same sort of things we were doing 5 years ago and actually isn't genuinely engaged in the sorts of things that communities are telling us they want to see from our services. So, a little bit about engagement. I've said this, I think it's absolutely crucial. Commitment of exec team. Commitment, and I mean commitment, I don't just mean tacit acceptance, I mean genuine commitment of what we're trying to do, I think is really important. We've been fortunate that we've managed to get that in the right place. And you just have to keep at it. It's not easy. You have to keep it at the top of the agenda despite all the competing financial and clinical priorities. It's not something you can just do until the CQC say they're coming and then, you move on to something else. Senior leadership is really important. I've been fortunate enough, I'm the most senior mental health director of the trust, so I've been fortunate enough to give it my push and my involvement, chairing the steering group and having the good fortune of being involved with colleagues on the network. Very specific project management. How do you do that with no money? How do you begin to get that in the right place? Well, you have to do really creative stuff about your existing team and make sure you get some dedicated time around this, because it doesn't do itself. You can't set up training, you can't set up all the community challenge groups. You can't do all of that unless you've got people pulling that together. And we've managed to do that by a variety of means, which I probably won't go into now. Something crucial about co-production, which I said earlier, I think is absolutely at the heart of this. When we're working with people who are saying we feel excluded from services, we do not feel we're getting a good deal when we try and access mental health services, and when we do access them, our experiences are negative, then it's absolutely crucial that co-production is absolutely embedded at the outset of that. If you don't get that right, it's just more being done to, and more embedding the sense of lack of power. And what we're really trying to do with this project is empower people and empower communities to challenge us about the services that we deliver. And then the other things I'll say very briefly around links with mental health initiatives, different mental health initiatives in the area, and in terms of our engagement with the voluntary sector and healthcare, Social Care County Council. A crucial thing is around the universities and the research and innovation. I'll say something about why I think that can be really important for people who are looking at doing something similar in a moment. Let's just take a few moments just to talk about, I'll finish shortly. Just take a few moments to talk about the challenges. I think the impact of organisational restructures that come along based on SIPs and QIPs and all the rest of it are a real challenge to any organisation. So how do you retain your focus? And it's really important that you retain your focus on this work as you go through those organisational challenges. We had some issues around recruitment and retention of service users. That's a real challenge for us and something that we're working with our service user involvement team on. It's a constant challenge. How do we make sure that when we get service users, we support them effectively? People with lived experience are absolutely crucial to what we do. How do we make sure we keep them, support them, work with them, train them? Engagement of non-BME staff. This is a really, really interesting one, actually. Because some of the challenges we had internally from non-BME staff were really interesting, and partly it was around the challenging nature of the training, and partly it's about that thing that people say was, why are we focusing on this? Haven't we got other things to be doing? I don't think we've got a problem. Where does the data say we've got a problem? All of that kind of thing. Now, you have to really get inside that right at the outset and have the honest and difficult conversations with people, which has been, I think, challenging and ultimately really rewarding, actually, when you see the journey that, I've used the journey word again, but you know what I mean. The journey that people come on, and we've had some really interesting conversations around that. So in other words, you've got to engage the whole trust. This cannot be just something that happens within the BME network at the fringes of a trust's activity. Really important that it's not that. Some work around service data that we haven't got in the right place at the moment. That's an internal challenge. One of the issues, I think it is a challenge, it's not something we failed as a challenge, it's something we haven't really embraced yet, is the crucial thing that Dr. Vivian had at the outset, which is within the term reverse commissioning, how do you engage commissioners? Because the original thinking was, once you get the community engagement, begin to work on the changes you need to do with services, check it out with your data, work with your service users, then you go to commissioners and say, these are the sorts of things that we want to think about as commissioners in terms of commissioning. That's the bit that we haven't got to yet. And it's partly because commissioners are busy, and it's partly because we're still doing it. So that's a real challenge for us. And the other bits are just around ongoing funding and project sustainability, which sound like small fry, but they're crucial. We think we've got the right leadership to sustain it. It's just about making sure that we can viably fund it going forward. A little bit about research and evaluation, innovation. This has been absolutely crucial. We've got an R&I team that we've got all over this right from the outset. We've got action research projects going. She's accessed a whole load of funds for us. It really helps us to ensure sustainability. We've worked really closely with different organisations, and including the local university. So this has now become a wider thing than just the trust. It's become a Northamptonshire-wide issue about how we begin to improve services, people from BME communities. A little bit around the stuff around the trust data that we captured. It was analysed to show variance. We've repeated that. We'll continue to do that. We've set up the PPI awards, which is a small regional award around patient and public involvement. So that's been really helpful. And also the special research interest group that I'll draw your attention to at the bottom, that's brought academics from local and regional universities and CLARC, the Collaboration for Leadership in Applied Health, including their Centre for Black and Minority Ethnic Health, and University Patient Engagement Forum. So we pulled all of that together locally and said, how can this make this project sustainable, and what can we learn, and how can we make sure that the learning from this genuinely becomes a proper action research model project with associated feedback and funding. So we've done our best to embed it in a wider construct rather than just make it a localised piece. So what's the focus? Clinical services that meet the needs of BME communities. You can only do that by engaging the communities, challenging your staff. You can only do that by having the honest conversation about, well, if you think we're in the right place for everybody, I'm not quite sure that's where we need to be. I don't think that's quite right. We've got to really get inside because the national picture is pretty clear about the discrepancies. And whenever you've got the sorts of statistics that we see around sectioning, around access to mental health, we need to take it incredibly seriously. I think apart from the moral and legal responsibilities we have to our community as a statutory trust about how we improve services. My starting point and finishing point is absolutely, and always has been for a number of years, around how do you enhance patient experience, how do you improve patient experience of services, and how do you do that specifically for groups from BME communities that have had hitherto poor experiences of mental health services. How do you do that? How do you really get inside that? And you do that by hard work, by talking, by changing referral pathways, by really challenging attitudes, by beginning to do staff training on a sequential basis. How do you get effective and lasting partnerships with local academics and with local organisations? And then I think the really key thing is about that we continue to work incredibly hard to make sure that in 3 years' time, our service user, lived experience, recovery model, recovery college, all the things we're trying to do as a trust, has the experiences of BME service users and carers and families at the very heart of it, driving it, and not as an adjunct to an afterthought. So that's in a sense, the crucial future focus that we're going to do. I think I didn't do too badly. Was that half an hour? I think I might have gone slightly over the 25 minutes I said. That leaves us a bit of time for questions. Are you happy if I stop there? It feels like the right place for me to stop, given that I'm drying up. I hope that was a relatively painless overview of some of the things we're trying to do, some of the challenges we have, and some of the honest, potentially clumsy and clunky attempts we're making to improve things. Really happy to take challenges, questions. Judith will be happy to take any questions as well. Any comments? I'll sit over here.
Hi there, Vera from the CQC Mental Health Policy Team. Thank you very much. That's really interesting. I have an observation and a question, please. Firstly, right at the very beginning, you kind of apologised for kind of taking this out of the integrated services sphere. And I thought, for me, looking at this, that actually the fact that it is part of that wider integration is actually why it works, and that it's not an add-on. And I think from a CQC perspective, it's interesting for us to think about how, when we come in and look through our key lines of inquiry, how we pick up on this through our look at integrated care. And secondly, I have a very specific question about the lived experience model that you mentioned, and I was wondering if you could tell me more about that in terms of, you mentioned service users and the importance of those with lived experience and then bring them in. If you could explain what you meant by that, and if it's just for service users or staff as well.
So, is this microphone on? Yeah. So the first point about integrated is absolutely right. I mean, I think where we've tried to come from is that we want to try and integrate the improvements we want to make within all services. So it's a fairly broad-based conversation that we're having. So I think you're right about that point. In terms of the specific issue around people with lived experience, service users, carers, we have an existing service user involvement programme that's been very successful over the past 2 years. I work with our local patient engagement group within the Trust, and we've seen a real, I think, change over the last few years in terms of some long-standing service users who are absolutely superb, but tend to be the same people that you work with over a period of time. We've been very fortunate that we've worked with some people with very, very recent and existing experience of very serious mental illness, and people who are working with them as carers and their families, involved in the patient engagement group, involved in our service user involvement. We've got 60 or 70 people with lived experience working with our involvement team at the moment. My point about that is, and the point I was trying to make earlier, was what we want to do is to make sure that that group is representative. So do we have young black males with recent experience of being in a PQ who are still experiencing psychosis, or are we not getting the right requisite examples of people from across the wider pathway of mental health? And that's where I think this has been a catalyst and a conduit to make sure that the representation is in the right place from service users, and that's also in terms of carers as well. Are we reaching out to people in communities who wouldn't put themselves forward to be involved in a mental health trust patient engagement group, for example, and get to a position where they feel comfortable, confident, supported to be able to come along to that, share their experiences and work with us. We haven't got that right from lots of different communities, whether it's the Somali community or whether it's, lots of challenges from local communities about saying, how can we get involved? We're a bit nervous about it. We're concerned about what that would look like. So we've done a lot of work on that. In terms of the wider piece around recovery and our whole IMROC piece, then that's just a great piece of work we're doing at the moment about how we embed recovery and co-production across the whole trust in terms of the work we're doing, and how we can, plenty of people have got recovery colleges. We haven't got our recovery college up and running yet, but it's something that we're actively involved in doing at the moment. Is that helpful? Thank you.
If I can add something to that as well around the startup of the project, we actively engaged a third sector organisation to help us engage with our community members who had those lived experiences of accessing mental health services, and also carers. And some of the key points that were raised to us through that medium is that actually as a faith group we work with those individuals who haven't yet accessed services, or we don't know where to signpost them in order to be able to gain that access. So I think that has been fundamental to us understanding what some of those needs are of our community service users and carers, and being able to embed that into how we're delivering this particular project, having that as the underpinning mindfulness around how we deliver the project.
Yeah, I think that's really important. I mean, focusing on community engagement and primary care isn't just because it was easy. It's because if you're going to turn the tap off, you don't want people coming into the service too late, too ill, too distressed. You want to try and get to people early as you possibly can. And we know that some communities are less likely to come forward earlier than others, and that's the work we've got to do. We know that.
Hello, I'm Gilla Rookby, Social Interest Group, Equinox and Penrose. One of the things that we struggle with, and I wondered if you've managed to crack, is the number of people that we are supporting with mental health with a severe alcohol problem and also substance misuse problem, and whether or not you've got any good examples of how you've managed to treat both at the same time, because often we find that the clinical team won't engage with somebody who is still using alcohol all the time, or if they're using drugs all the time, they'll not see them until they've gone and done a detox or something like that.
There's a very long and detailed answer to that, which I won't go into now, but we might pick up outside of this room. My background clinically is partly for a number of years in drug and alcohol, and I've got experience of engaging the Kashmiri community in Peterborough 20 years ago, for example, around some opiate use issues and massive underrepresentation in terms of how they engage with our services. So I can talk to you about that. In terms of at the moment, I think one of the challenges we've got within mental health is actually the way that drug and alcohol is commissioned. So, for example, if I'm honest with you, I would love to sit here and say that we've got a handle on the whole pathway of dual diagnosis, call it what you will, drug and alcohol. Because there's all sorts of issues there about language we use around drug-induced psychosis that I'm not entirely happy with anyway. How do we do that? Well, we don't, because we're not the providers of the services. So we have to do our best to work in partnership with the independent providers who are commissioned by the local authority through public health for those contracts. So I think that's a real challenge for us. I think it's a real challenge for our commissioners as well. About there seems to be a bit of a disconnect over the last few years between mental health and substance misuse, which I think is a retrograde step and possibly problematic. How we do it within our trust is we do what we can to understand that we don't exclude people with drug and alcohol issues, and we've got some very skilled and trained people who've got experience of dual diagnosis and how we do that. But where it begins to get tricky is the partnership working that you want to do then, in terms of if people are also getting support from other organisations. I think that's a challenge for all of us. I'm not sure we're particularly great at it.
I think it's probably the flip of that as well, because our experience of substance misuse services,
I think the flip of that is often our experience of substance misuse service providers won't engage with somebody who's got a severe enduring mental illness, and there's that no man's land really that we've got to overcome.
Absolutely, and it's from personal experience, from professional experience, it's really difficult to untangle those things. And as somebody who worked both in drug and alcohol and in mental health, and actually kind of worked in both at the same time dual diagnosis, it's really, really challenging to kind of have some sort of demarcation of where substance misuse stops and where mental health begins. I think it's a real challenge for all of us.
Hi. I just wanted to talk about what we've been doing locally in Hackney, because our data is very similar to yours, if not more stark. So 80% of our service users on community treatment orders are from BME communities and etc., section rates, admission rates. So we looked at engagement, and actually we have worked really hard on access to psychological therapies, and from that perspective we have succeeded in representing different groups' prevalences in services, so that's great. But what we noticed was people fell out from the traditional CMHT use. And so we decided to kind of see if traditional services couldn't engage, who could engage people.
Yeah.
And for us locally, that was a voluntary sector organisation, Core Arts.
Yeah.
So we have commissioned Core Arts, who are a non-therapy organisation, with very tight asks of them to see more than 75% BME patients, all on CPA. We have asked them to reduce readmission rates, increase compliance with medication. And, you know, we were kind of expecting as commissioners that they might just laugh and say, are you joking? And they said, yeah, okay, fine. And they've done it really well. And it is about that, I suppose, that leap of faith from a commissioning point of view to think that a non-therapeutic organisation that does a lot of therapeutic work, if you know what I mean, they're not clinicians, can engage much better on the recovery pathway. Yeah. So for us, it's been absolutely fantastic. How we sustain that funding is really challenging.
It's really interesting.
Hello, I'm Antonia from NHS England.
Right.
We're being recorded, aren't we?
Yeah, we are. You have to speak into the
I'm
microphone.
still getting
It doesn't make it very free and fluid, and
It's okay.
but you have to do it.
But just want to. I think I want to talk. Okay, so just a second.
Yeah.
So I'm part of the new 5-year mental health forward view programme, which is investing over the next 5 years in IAPT and crisis services and a secure care pathway and maternity and so on. And I think it's really important that we all do what we can to ensure that, as we say, accessibility for everybody, and particularly the most disadvantaged people in the system, is at the fore of all of that work. Now, I can speak for the Secure Care programme, which is the decision has absolutely been taken to do that, and we are prioritising the sort of community service offer for everybody and specifically for black men, because that's an important decision to take and do something about it.
Yep.
So the challenge, I think, is how to understand how to take really valuable, innovative approaches like this from a sort of a locality that has specific local needs to respond to kind of pull up the intelligence from that to national level to inform what we expect of commissioners. So NHS England is concerned with what CCGs do.
Absolutely.
So it's all sort of distilling a little bit in a way, but it's even knowing. I think it's very important that NHS England as well, in doing that work, doesn't try to create anything totally from scratch, because there are existing excellent pieces of work, and I think it's about trying to learn whatever has been done and what is emerging. So I guess my question is, it's sort of a point that I want to make, but I guess my question is, can we talk? If this is part of a pilot that several providers are involved with, I think for us to understand what we need to pull up in terms of the commissioning ask, we need to understand what's really kind of grown organically and how on earth you replicate the kind of organisational culture and change that is required to deliver any specific service.
Yeah, I mean, one of the reasons I agreed to move from the status of delegate to standing on the lectern, much against my better judgment, was precisely because, I'm not, I said at the outset, I'm not saying this is a magnificent kind of exemplar of wonderful practice, but we're really, really proud of what we're trying to do. Northamptonshire isn't London. It's an East Midlands county. It doesn't have, as I said earlier, a particularly strong provenance in this area. We've had really good experiences of different bits of excellent work over the last 20 years, but it's sustaining that. We're really happy to share what we've done. We think there's lots of learning in it. We think there's lots of learning specifically for organisations that want to think about creatively how they can get the right sustainability and traction within an organisation around governance to make some of these things work, and also how we went about our community engagement, the service user engagement piece. So really, really happy to have those conversations with you. Because, the whole point of this is, without being Maoist about it, let 1,000 flowers bloom. And I think you're right. I mean, the last thing you want as NHS England to is impose a model about how you will, engage with communities and mental health services. could be problematic, I think. So, yeah, really excited to talk about that. Yeah, absolutely. Yeah, absolutely.
I think the framework is fantastic.
Yeah, superb.
And NHS England, we would see as being leaders in how we actually construct that, but it can't be done without the cultural shift.
Yeah.
And we'd have to say the success of NHFT in this instance has been about having those open conversations and being honest about what we're seeing, and then using that to drive cultural shift, which then underpins the delivery and the success factors for this project. But one cannot go without the other.
Yeah. So we really welcome the support and leadership of NHS and we'll give it right there. We're really happy to be involved in that conversation.
Hello, my name's
Hello.
Rita Ram.
Hi, Rita.
I'm from Dementia Partners.
Hi.
We have a pool of experts by experience. They're service users or family carers of people who use services. And the question I have is regarding monitoring and a fix-it approach. So I understand from your presentation that you have co-production events, which are very helpful. But I'm interested to know whether you have service users going in regularly, we call them our team experts by experience, getting information and fixing as you go, instead of a co-production regularly where people are reporting general patterns and themes. So my understanding from the service users and the work we do is if the service users go in frequently and speak to other service users about their day-to-day experiences, and then that information is reviewed and the problems are fixed as you go. Whether that was, I was wondering whether you adopt that approach.
We do adopt that approach. I mean, I think it's embryonic, but I think we do that across older person services. We do that in dementia services, and we do that in our adult services as well. We've got quite a robust PALS and PEG. These are acronyms, but our PALS and our patient engagement group work very closely, and we've got people with lived experience who are on the wards frequently. We want to develop that into proper, sustainable peer workers as we move forward in terms of the recovery model. And we think that that's an excellent model, and that's something we certainly want to develop and explore further. I agree with you entirely that unless you've got that kind of active dialogue on the ground and people being able to have those conversations and report back really quick and lean, then otherwise you certainly don't want to wait for some kind of meeting in a month's time to begin to pick up the issues. So I think that's certainly an approach we're working with at the moment. It's I think very positive in terms of feedback from our service users and carers.
That's our experience too.
Yeah, no, absolutely. I think it's absolutely the way to go. It sounds like you're ahead of us on it. But
Hi, I'm Adil Jawad. I'm a consultant psychiatrist working in Crawley, Sussex Partnership Trust. And I've got my colleague here, Dr. Bukul, who's also a consultant psychiatrist. We have been doing a bit of this ethnic minority work in Crawley, which actually has about 30% of ethnic minority population. And we are engaging with the CCG and the ethnic minority patients lead, and we are trying to engage with the community leaders, but also the religious leaders, as there are about more than 50 different languages spoken in that area, to find out what the hurdles are for people accessing mental health. Because there we did an audit last year which found that only about 4% are accessing our services. So we want to psychoeducate these people, the community leaders and the religious leaders, and also find out what the hurdles are in accessing mental health, although we know some of things like stigma, etc. My question is, we are thinking about an idea of starting an ethnic minority clinic based in GP surgeries, not to segregate these people, but as an add-on, possibly as a pilot to begin with, to see whether that would actually help improve access to mental health. I would like to know your thoughts and views on this.
Well, my thoughts very simply are, if that's what people are asking for and you think it'll work, then run with it and see how it goes. I mean, I tend to take a very pragmatic approach to these things. What is it you think that people are going to get out of that? What's it going to achieve in terms of improving access and health inequalities? If that's something that you think is what works for that community, then you know, I'm a great believer in looking and trying these things. I mean, we had something very similar in drug and alcohol a number of years ago. We had to do some very, very specific clinics for different populations to improve access, and I think it worked very, very effectively. We're not doing that at the moment. That's not what we're considering in our area. But I do know that specifically commission services are taking place not just in Hackney but in a whole range of other areas. And I spoke to a colleague, Malcolm, who's working for Hestia, and they're doing some fantastic work in Ladbroke Grove around specifically commission services for people from BME communities. So yeah, I mean, my view is let's see how it goes. I mean, it sounds definitely something you'd want to try and evaluate. Sounds very exciting.
My name's Janet Clark-Lewis. I'm with the African Caribbean Community Initiative in Wolverhampton. Firstly, IAPT is a sore thorn in our side at the moment.
And mine.
Yes. When IAPT was initially started, we talked about the cultural approach and how services in terms of GP services, so the initial health services were failing black people in terms of not offering them psychotherapy or psychological therapies initially. They commissioned us for a short while, gave us an impossible target to meet, and then took the service away. Today we find that we have, that we are the Healthy Minds referral service.
Right.
So we're getting in excess of 8, 9, 10 people per week, and they're not just African Caribbean. You know, it can be anybody. And whilst we had always said in the beginning that yes, CBT or that type of therapy is good for some, it is not always good for others, and that has been totally negated. So I feel a little bit frustrated that they continue to roll out the programme and not properly address the cultural issues. With appropriate agencies, not just black agencies that can provide alternatives.
I'm glad you've had the opportunity to say that, and I'm sure there's people nodding in the room about the challenges that IAP services, both from a commissioner's perspective and a provider's perspective, give us all. Yeah,
so
absolutely.
it is difficult to say, particularly as it's kind of being broadcasted. So I'm sitting here thinking, do I say too much?
No, you're being both articulate, clear and precise around some of the challenges I think we've got with IAP services. And that's something that we're certainly wrestling with, as I said, in terms of how we make sure that our services are focused on making sure we're getting to people who otherwise wouldn't access those services. I mean, it's a very, very cold, old-fashioned kind of view. You know, you look at what you deliver. Are you delivering it to the right people? Is it really representative of the population? And if we think there are people that aren't accessing it and are more likely to be given other therapies because of how they look or what language they speak, or whatever it happens to be, then we need to challenge that, and we need to test it out by going to communities and working on that and talking to commissioners. And I think it's a real challenge. Apart from the don't start me on the targets of IAPT around recovery and all the rest of it, because that's a real challenge for all of us. But yeah, no, I think it's a very valid point.
Yeah, we've got around that by getting funding from elsewhere for 5 years. So we're operating what we consider to be quite a successful and integrative practice to service users.
And just on that, I mean, the last thing is, I mean, I'm aware of time. Is there time for one more question, or are we done? Oh, one more question at the back. We've got just a couple of minutes before lunch, and I don't want to detain you.
There's time for one more question.
Oh, time for one more question, right. One more question over here, sorry. So I can't see with the lights, so it's...
Hello, Colin Keegan from Equinox Care.
Hi, Colin.
I was just very interested in your comments about staff training, because all too often, I've heard staff, and I've been in the experience where it's a very tick box exercise, or it leaves people fearful about what to say or what not to say, or what to do or what not to do. And it sounds from your comments you found a training or provided a training that really challenged assumptions and was difficult for people perhaps to embrace, but I'd just be interested in hearing a little more about it.
Yeah, I mean, you're right. That's what we've done. And it has been really challenging and absolutely the antithesis of tick box. And it's got people into, kind of to challenge their own practice, to challenge what it means to be a mental health worker, what it means to work with people, some assumptions that that everybody could develop structurally over the years, and some specific issues about concern around risk, all the things that we know about. So we've done some specific detailed work on that. Judith's been involved in that quite a bit. I don't know if there's anything you want to say just to...
I think you're absolutely right. The tick box we found only serves the purpose of the organisation's needs, really, that we've undergone that training. But it may not necessarily do the shifting of thinking and shifting of attitudes and shifting of culture that's absolutely essential to become more inclusive. The training package that we developed was from the original exercise, the original outset of the project, was very much based on for the service users and carers, understanding how do we engage with this great big lofty thing called the NHS, who we don't even know how we access services, and we just literally, take what's given to us. So it's
and I'm acutely aware that it's 1:03. People will be hungry. I'm really, really grateful for you coming along today in the room. I didn't know how many people would be here. So thank you very much for letting us share what we're doing with you. Happy to talk to anybody individually afterwards. Hopefully in a couple of years' time we might have another conversation about where we think we've got to and how pleased we are with it. Okay.
Thank you.